I think we're a little tight for time, but that's okay. You'll see my second disclosure slide and tell us why we really don't need a lot of time for this topic. Although I will say that this is a very serious topic and something I talk a lot about in the community, in particular with primary care audiences. So again, I'm going to talk about staph in the blood and swollen pockets. And basically this is to talk about device infection. Just keep in mind my relevant disclosures for this talk. I receive research funding and I provide consultancy to Spectranetics, which is a company focused on weed removal. So driving into work this morning, probably should have both wheels on the, both hands on the wheel, but instead I had one hand on my iPhone up in front of my windshield capturing the slide. So I call this the Captain Obvious message. I did not need to be reminded on I-40 this morning to reduce my speed or watch for snow and ice. This message about device infection, the only thing you need to remember is that the only treatment for a device infection is total and complete removal of the entire system. Lecture's done, we can now go back to the general section. So we'll talk about this in more detail, but this is really all Captain Obvious things. Not obvious for those of us who don't practice cardiac electrophysiology every day, but critically important to remember because in primary care you are on the front lines in the trenches, under duress all day long, and so these patients usually present to you, and you are in a key opportunity to catch these patients early. So we have a marked increase in cardiac device infections. In fact, over the modern device era, the prevalence of device infections has increased over 300%. And the increase in device infections is outpacing the growth in the implanted devices. So you could ask, well, why is that? And there's no one answer. But among the answers are devices are more complicated. We're putting in more high voltage devices. We're putting in more devices that have multiple leads. ICD patients live longer, and so age is a potent risk factor of infection. Comorbidities are more frequent. So your average ICD patient, their problem list is now the size of your arm, whereas before it used to be the size of your hand. So their risk factors for infection are going to be increased. And tragically, the little buggers are also changing as well. So this is pretty fascinating work done from some of our colleagues here at Duke that Staph aureus isolates from device patients. It's pretty disturbing. Strains that have polymorphisms that have increased binding affinity to fibronectin are becoming more common. So it's not just our patients are changing, the microbiology is changing. And one of the dirty little secrets about device medicine is that every time we open the pocket or instrument the device, the risk of infection goes up. And that's because scar tissue has less perfusion, and so it's more likely to get infected. And it also, every time we open the pocket, another dirty little secret is that every single patient with a cardiac implanted device has a subclinical infection. There is some small amount of bacteria that's walled off in that pocket. And it's like playing Russian roulette. Every time you open their pocket and stir things up with the bovie and expose blood there, that's increasing the chance that subclinical colonization can turn into a clinical infection. This is the star of our show today, okay? I looked up Staph aureus for this one article and I got this picture instead. I was like, ooh, I have to put that in the talk because I haven't seen that since my second year of medical school. And if we look at who are the bad guys, a third of our device infections, if not more, in modern and contemporary times, because this data is a little dated, are due to Staph aureus species, and over half are due to Staph species in general. And this slide I stole from Rob Lewis, one of my colleagues, and it highlights the point that device infections can be sneaky. So how do they present? The bad news is they really don't have a uniform presentation. They can present just about any way they feel like presenting. If you want to remember what is the most common way they present, the most common way they present is pain, erythema, and calor at the implant site with a pocket infection. Systemic infection can present differently. The other dead giveaway is when you see someone and their CBC has always been normal for a bazillion years, and they come in with a vague sense of fatigue. They have a cardiac implanted device, and now they have their crits fallen 4 or 5 points. Chances are that patient has an implantable cardiac device infection and not a low-grade GI bleed. What is the differential diagnosis of pocket pain? People complain about pain in their pocket all the time. If you are seeing someone who is 6 months after their device, this is the differential diagnosis. Infection, 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 infection. Not by frequency, but by the seriousness and the suspicion you must have for the diagnosis. Pain can also be caused by a very thin pocket or a pocket that's too tight. Pain can be caused by a pocket that's too high so that when they bend over or laugh, the device bumps up against the clavicle and gives them like a shock light type pain. Clavicular, we call that clavicular impingement. Neuropathic pain is common. Upper extremity DVT can present with pocket pain. The way to figure that out in the office is you palpate their axilla, and that gives them worse pain. Chances are that DVT is more likely than some other etiology. And then allergic response hypersensitivity reactions can also cause pocket pain, particularly if someone has a history of multiple device infections with no bug uncovered on analysis. A pocket exam is extremely important. A normal device, you should be able to move under the skin, okay? It shouldn't be adherent to the soft tissues. It shouldn't be fixed in the pocket. There should be no warmth compared to contralateral chest. So what I do is when I see my device patients, I flip the back of both hands on both their device and their contralateral side. If the device side is warmer, you should have a very high suspicion. Sometimes you'll get fooled because some people fiddle with their device site, rub it, and all sorts of things, and that can make it warm. But in general, if there's increased warmth, that's concerning. And there should obviously be no erythema and no fluctuance. So if you suspect one of these guys, what do? If you suspect you may have a patient with a device infection, you can send a sed rate, send a CBC with differential, and please send 2 blood cultures. Do not give them empiric antibiotic therapy. But please call the implanting physician or your local friendly EP doc, because it's critical that that patient be brought to EP clinic and examined by a device physician. Sometimes, on rare occasion, it is a stitch abscess, or it is a very unlucky placed boil that happens to be just next to the device. But those are very difficult calls to make. I'll tell you, I focus on these patients a great deal in my practice, and I have a hard time a lot of the time figuring these things out. So please send them to us. This is a really difficult case that I think emphasizes a lot of points we've made. This is a 58-year-old woman who was sent to me from an academic institution in the southeastern United States. She had a history of AV node ablation for atrial fibrillation, and as such, she was pacemaker dependent. Her coronary sinus lead did not capture, and so she had normalized her ejection fraction, and since it was stopped capturing, her EF had fallen, and she slowly was accumulating heart failure symptoms. Her primary EP went in to revise the system. She had an occluded axillary vein. They failed venoplasty and they failed the lead extraction. They replaced the generator, and then for the next 6 months after the procedure, the patient kept complaining of pocket pain, and it was very impressive. Sitting on the table, she appeared fine. Palpating her device, she felt fine. The minute she abducted her arm, she about screamed. And this pain was present for several months. And interestingly, when she was given empiric antibiotics shortly after implant, because she had some mild redness, her pain got dramatically better. Her sed rate, her white count was normal off antibiotics, and all blood cultures are negative. Kind of a tough case. The pain's very concerning for infection, but everything her docs checked out. So what did we do? We sent her to nuclear medicine. She was our first patient at Duke that we did a PET scan on. And these are not images from her case because I could not get them on CD-ROM due to the snowstorm. I apologize, but this really shows what we saw in her scan. She had an area of hyperintensity and FDG uptake in the inferior aspect of the pocket. And so we diagnosed the pocket infection. When we took her to the OR, it was very clear that she had inflammation in the base of her pocket and a subclinical device infection. What not to do? So this is a note from our healthcare system written by an infectious disease specialist. And I am not putting this in the talk to suggest that our infectious disease colleagues don't know what they're talking about. I think at Duke we're actually extremely lucky. Our ID docs are some of the world's greatest experts in this field. But this is an ID doc who doesn't see device patients as frequently. And so, again, I think the most important thing with these patients is getting them in front of someone who is familiar with device infections. And so this ID physician suggested that if there was fluid, we should aspirate it. And the one thing we never do with devices is aspirate the pocket, because if there is an infection, there is very likely to be one after you've aspirated it, because you're introducing potentially infection into the pocket. So what do you do when you make a diagnosis? And I'm now breaking my promise of moving quickly. You need to remove everything. You need to completely debride the pocket. You need sustained antibiotic therapy, and if you do reimplant, it needs to be at a new site. We have consensus recommendations regarding management of patients with device infections and extraction, and I want to point out that infective endocarditis, pocket infection, or occult gram-positive bacteremia are all class 1 recommendations. And Al's son is brilliant, but he did make one big error this morning. He said a number needed to treat of 8 and made it to long-term follow-up is an amazing number needed to treat, and there's no other intervention in cardiology that has a number needed to treat better than 8. And there is one. Laser lead extraction, complete hardware removal for a device infection, number needed to treat 1 to save 1 life. And why do you have to take everything out? I hate to admit when our field is similar to orthopedic surgery, but this would be, and my best friend's an orthopedic surgeon, this would be one of those times. Foreign material provides bacteria with a privileged anatomic site that the immune system cannot access. So until you get the foreign material out, the patient will not achieve cure. And I'm not just making this up. There's lots of observational data that show very high risk relapse rates, and there's Duke data also that shows the mortality about 20 years ago when we didn't remove these devices routinely was over 87%. And again, that's why we have a class 1 indication. Lead extraction, complete hardware removal with antibiotic therapy is a life-saving procedure for these patients. And you know, this is a cartoon that says, ask your doctor if taking a pill to solve all of your problems is right for you. So yes, there's so many things we love to treat with a pill. Unfortunately, a device infection is not one of those things. And this is an algorithm that I don't want any of you to remember. It highlights a couple of features. When you get patients seeing you in the office and you may see, well gosh, this guy got 6 weeks of IV antibiotic therapy, this guy got 2 weeks, what's going on here? The duration of antibiotic therapy, how soon we reimplant the device, a lot of our decisions are based on, do they have evidence of vegetations on the device or their heart, and what is the pathogen? And we treat Staph aureus with a much longer antibiotic regimen. Again, you don't need to remember any of this. You send them to our service, we take care of all these things in combination with our infectious disease colleagues. Just in case I haven't beat the dead horse enough to everyone's pleasure here, these are 1-year survival rates after a device infection, depending upon whether the device was removed at the first hospitalization or subsequent hospitalizations. And the reason this group could do this analysis is that a lot of patients get admitted. They get antibiotic therapy and they get a script that says, 4 weeks antibiotics, repeat blood cultures in 2 months. And when patients don't get device removal in the index hospitalization, you can see that their outcomes are much worse, and this is survival. And again, highlighting the benefit from this procedure or appropriate treatment of a device infection, this is an 18% absolute risk reduction in mortality. Now, these are observational data, so they're not randomized, but the point here is that these are serious illnesses that can be cured only with complete hardware removal. And again, we see the same thing. If you look at another series from an EP group, again, immediate device removal is associated with much higher odds of survival. So, number 1, maintain an extremely high suspicion for device infection. Pain, erythema, and warmth at the implant site are the most common symptoms and should cause great concern. If you suspect infection, refer or contact the patient's implanting physician. Pocket infections and occult sustained bacteria require complete hardware removal. And now for the last humorous slide. Okay, who are you going to call? You can call my partner, Don Hagelin. You can call me. Or you can call Rob Lewis, who's at Duke and has been at Duke for a long time now, but he doesn't have a picture on the website. So I was like, well, Robert Lewis, it's because that's a common name, right? His full name is Robert Kenneth Lewis, so I typed in Robert Kenneth Lewis into Google, and a gentleman with amazingly similar demographics comes up. However, he's an inmate at a state correctional facility. Coincidence? I don't know. But in all seriousness, any of the three of us will take a call 24 hours a day, 7 days a week. If you have a patient you're concerned about, please reach out. We are thrilled to help you with any problems you might have and get the patient better. And thank you so much for your attention.